we'll talk a little bit about healthcare now. We haven't really discussed this much, so at first I'll tell you a little bit more about AI in healthcare broadly, and then more about PCCI. So at first we'll introduce who PCCI is and one of the main partners at Parkland Hospital in Dallas. And I'll tell you the overview of healthcare AI and a little bit of adverse drug events and sort of how we use AI to help catch those early. And I want to discuss a little bit about the overall model life cycle. I didn't necessarily see this being discussed, like what is a full data science life cycle from idea, scoping to implementation. So we'll discuss that from that framework, and then we'll dive a little bit for the geeky people for the actual details of the model. And then I'll jump up and then talk about, again, what are the lessons learned and what are the sort of drivers of success that we've encountered in applying AI. So PCCI is a healthcare intelligence nonprofit here in Dallas. So we try to improve healthcare outcomes through many different ways. One of it is connecting communities and optimizing how hospitals work. So we have a unique team of clinical, so MDs, so people who actually know what the actual problems are that physicians face every day, but they're also business owners and they have business training, so they understand how to translate those problems and find solutions. We have a product management framework in order to do that, and we also, of course, have the data science team. And so we all work together to be able to translate the business problem and deliver value. The domains that we work in currently are sort of, is there a pointer here or no? Yes. So our work, what I'll talk mostly about is in the section of hospital reimagine. So really trying to improve processes within the hospital, and that most relates to clinical care. But we also work with connecting communities, because a lot of your health depends not just what happens when you get really sick and go to the hospital, but what happens around you outside. Do you have a stable housing, for example? Do you have food to eat, right? So those are big drivers of your health, and so PCCI is working to connect the hospital with the outside world. We also work a lot on patient engagement, because your healthcare is not just what happens again to you in the hospital, what happens outside. So helping people remember to take their medications on time and feel connected with the community. We have an innovation part and research part to sort of help out other organizations with their sort of research efforts and choosing new directions. And a little bit about Parkland. Parkland, I'm not sure if you know, but this is one of the biggest hospitals in Dallas. It's over 800 beds. They've been an innovator in the healthcare IT space. I think last year they were in the list of most wired hospitals. So they've been a great partner, and they really have set up the data infrastructure and backend to be able to do this kind of advanced analytics and incorporate AI. So that's not necessarily the case for all hospitals today. And so this is my overall healthcare AI slide. Just what are the kind of issues that we face with, right? So I think most people, when you tell about the work in healthcare AI, they think you're diagnosing rare diseases. And that's probably a very small fraction of what healthcare AI is, right? That certainly is happening, but it's a very small fraction. So, for example, in the case of cancer, you could look at, say, genomic data. So it's a very heterogeneous disease, and so you can look at the genomic data and try to correlate which disease do you have and what may be the best treatment. So that's one application of AI. Radiology also has seen a big adoption of AI, where there's essentially you have to parse through lots of images, and instead of having a radiologist sit there in front of the screen all day, you can necessarily boost that with AI. And in fact, last year, FDA approved the first AI-powered radiology solutions for measuring how much blood essentially goes through the heart. But that's, again, very niche application, so there's definitely a lot of growth there using neural nets and image processing. And a clinical notes is also another interesting area, because clinical notes are very hard to read even to a non-physician, but even to a physician, they have a lot of abbreviations. And a lot of the information about your healthcare is in those clinician notes, so there's also a lot of natural language processing in order to extract information and determine the context of the note, so it can be used in a more structured manner. Healthcare, there's also the issue of accountability, right? So who's responsible for the decisions about your healthcare? And usually that's your doctor. And so they have gone through extensive training, and so they're the ones accountable for what decisions they make, right? So AI at this point is not going to be your MD, and they're not going to replace your MD. But AI can certainly help with safety events. So what that means is that, for example, we have models to catch people who are about to develop sepsis, which is a very bad form of infection. So there you have to essentially parse a lot of data and notice tiny little trends from a lot of different sources. And so sometimes humans are not that good at doing all of that, and the machines are able to catch those events a little bit earlier. So that's a very good use case where you can use AI to go through a lot of data very quickly and perhaps catch the disease progression a few hours earlier, and so the doctors can start the antibiotics, right? But that's not necessarily diagnosing a disease and choosing the decision course later on. And the project that I'll talk to you today falls under this general resource optimization, right? You have a lot of services you can provide, but it's too expensive to provide to everybody, so how do you identify the patients who would most benefit from that? And it's most cost effective. So healthcare also has the interesting characteristics in terms of their regulation, right? So your healthcare data is actually very protected. There are laws against they can't be shared across. So not necessarily all of it, but you can't necessarily share data that will identify you as a patient. So that also puts some constraints in terms of, you can't just spin up a quick AWS server and run the data there and come back, right? There's issue with experimentation. So you can't do A/B testing on patients. That's technically called a clinical trial, and you can do that, but that involves several years of development and several millions of dollars. So there are cases, and we are running clinical trial, but that's not necessarily the way we sort of test out different hypotheses. And so you have to design around that and be able to evaluate different strategies. And goal alignment is also very, in terms of the people who take care of you, the people who pay for that care, and how you sign up for that, those are very disaligned at this point. So there's a lot of change happening in the healthcare industries about how payment is restructured and is it optimized. So for those of you who are more familiar, it goes from a fee for service structure to more value-based, what did you do that was actually beneficial for me, for my health outcome. And so in developing sort of solutions, you have to always take into account who would benefit from this clinically and who end up paying for it, right? And if you find a problem where those goals are aligned, then that probably has a greater chance of success. But ultimately, I think healthcare, some of these are sort of challenges and some of them are also opportunities, right? So how to work things better. The healthcare field is interesting, and you have a lot of impact over people's well-being. You're improving access to healthcare for everybody and having things more efficient. And you're contributing to the overall knowledge. So it's a very rewarding and exciting field to be in. And then healthcare and AI at PCCI, so I've sort of touched a little bit on this, but the work that we've done in the past has been a lot about the hospital reimagine, so let's just talk more about that. Again, predicting which of the patients after their discharge are most likely to experience complications and not follow up on their discharge instructions and come back into the hospital. And so if by identifying, say, the top 5-10% of people who are most likely to come back, then you can put extra resources and an extra nurse call them back and check up on them. So that kind of that has been a very widely accepted use case in healthcare, and a lot of hospitals actually nowadays are doing that. What I mentioned earlier is again capturing people who are likely to get sepsis, which is a severe infection, or early warning system for capturing people who are about to go into cardiac arrest, and again sort of intervene earlier. So in all of these cases, you're not replacing a human, right? There's always nurses and doctors monitoring everything, but you have this parallel alert system on the side, and occasionally it alerts a few hours earlier. And that's an opportunity, right, to intervene where the nurses then jump in and do something. We also have projects, so Parade is a project I'll talk to you about today, about patients at risk for adverse drug events. So this is more around the medications while people are hospitalized. We have projects in oncology. We have projects working on reducing the LOS is a term for length of stay. So even when you're done with your stay at the hospital, there's still a lot of procedures that need to happen to sort of get you out the door. So the faster you can do that, and that's more like a process improvement, the better you are. But that again also relies on reading clinical notes and AI. And we do also doing a clinical trial where we're trying to compare, can we leverage sort of from the back end IT technology to better identify patients and deliver the better care to them. And in the patient engagement aspect, we've also worked with, like sending text messages, reminders to people with asthma to take their medication. People forget, people I think overall understand that medication is important, but they have busy lives and sometimes they feel well, they forget. So it's sort of having some sort of bi-directional communication while they're not in front of the physician actually helps with their outcomes. And we're doing that for asthma and for oncology patients. So next I'll talk to you like the more specific project. So this is Parade Patients at Risk of Adverse Event, and this was developed by our medical director, Manz, and me as a data scientist. And so here's the project lifecycle I wanted to bring about. I haven't necessarily seen anybody talk about this yet at this conference, so I'll spend a little bit of more time discussing it. The idea is that what is the full life cycle? First, you start with business understanding, right? I mean, there's no business problem. No one's willing to take any data-driven solutions. You're not going to go anywhere. So you want to understand there's a business that could be potentially a business problem that could potentially be solved by the data. So then you go and you really understand what kind of data do you have? Can you really trust that data? Can you get it at the time that you needed to make that decision? There's a lot of time that you spend here, and sometimes data scientists are not necessarily involved in this part. This is sometimes carried out by business analysts, but I think it's important for the data scientists to also be plugged into this part and understand the problem as best as they can, because they're the one dealing with the data and making a lot of decisions about how they interpret it. Then once you've sort of decided to go forward, there's of course data preparation, and we've all seen the slides that data scientists spend most of their time there. I think it just really depends on the specific case you're in, and the modeling, of course. Again, choices of the modeling, we'll talk about that later, but that again depends on how it plugs into this whole cycle. You can have a very accurate, very complicated model, but if it doesn't plug in easily to deployment and drive your business value, then that's probably not the best one. And then the valuation, so you need to communicate results, make sure first of all, is this viable, is it working out as you hoped it would? Does that go back to the business understanding? Does that provide any value, right? Because if it doesn't, there's no reason to deploy it. And again, deployment. So this is the CRISP GM framework, and we do use it, but I think it's not necessarily complete because, after deployment, it's not like you just drop it and forget about it, right? There's always continuous monitoring and seeing business understanding. Businesses change very quickly, so again, you have to make sure there should be an arrow between deployment and business understanding. It's a constant feedback about, do you need to keep improving it, or are you running it well? So this is sort of my business understanding slide. I just want to show you the adverse trigger events are a big problem. So adverse trigger event is sort of broadly classified as any harm or injury that results from a medication use, right? It could be most often from, let's say, getting too much of a specific medication or getting the wrong medication or getting a lower dose than necessary, right? It's actually a pretty high leading cause of death. It costs a lot because then you have to provide additional care. And it happens a lot when the patient, say, goes into the hospital, gets discharged, and has to get transitioned from one place to another, and not everything is communicated very well. The workflow that has been developed in Parkland in the past is that, a patient gets admitted, some nurse asks them, oh, so what are your medications, what are you taking, and they give them a list. A lot of people, especially with multiple chronic conditions, they don't necessarily know the drugs they're taking, the exact dose, or anything like that. So there's a lot of errors that can get introduced to that level. And so what happens normally through the course is that at some point the doctor taking care of that patient will say, wait a second, that does not look right. I need to know much better what this patient's taking. So they'll call the pharmacist and say, you find and call all these pharmacists and find out exactly what this patient has picked up from the pharmacy, and what dosage and how frequently, and it's an enormous amount of effort of time to, as you can imagine, to do all of that. So you can't really do it for everybody, and it's just not a good use of a pharmacist's time. And so what they decided to do, so this workflow exists, but they had decided to actually augment it with some sort of analytics, right? So now they put in the score that upfront, as soon as the patient gets admitted, judges, is this patient at a high risk for having one of these potentially adverse trigger events? And then maybe we'll flag them in upfront, so this is more from pharmacy provided versus provider initiated. They'll provide the exact same service. So the final service that the patient gets, like the consult and the pharmacist calling, is the same, but it could be identified either by a human or it could be identified by the score. And so I think that was actually pretty innovative of them to be able to plug in this analytics score, but what they didn't necessarily really have analytics, so they just created a very basic literature-driven score, like, oh, well, this patient, has 10 more medications, give them 5 points. This patient has chronic liver disease, give them 2 points, right? So it was totally, it was a little bit driven on their experience in the literature, but nothing calibrated to the actual system, right? And so sure enough, they found out it wasn't really that good, and so that's where we were brought in to help out. So the old score was literature-driven, so we actually started looking at the data. We looked at the statistics, what do we know about the people coming in, what do we know about the ADs that are occurring to them. And we did talk about the users who do these and asked them, like, what kind of patterns are you often seeing that where patients really need these or patients really didn't necessarily need that service and it was a necessary time spent. And I think one of the biggest novelties that we brought is that also we really considered what are the outcomes. Like, so this is a big point, I think, in data science models, like what do you want to optimize in? There's a lot of things that are very easy to measure, but they're not necessarily as meaningful. And there are things that are meaningful, of course, that are hard to measure. And so I think that goes back to the business understanding and trying to decide what is the value that you want to provide and how to best set up. And sometimes that's not the very easy answer. So in this case, we actually wanted to optimize on 3 things. On sort of operational practices in terms of like picking out the patients that in the past had been requested as kind of surface, like what are their typical characteristics. But we also wanted to make sure we utilize the pharmacists correctly, right? So we wanted to find patients who'd have a lot of these changes that needed to be made and updates, right? And we also wanted to find patients who would actually would have had an adverse drug event and be prevented, right? So there's a sort of like 3 very different outcomes. So how do we reconcile all of that? That's sort of the data that we used. It's sort of, I think, very obvious that we used medications, we used the clinical data in the previous, if they had any previous clinical data, demographics and social determinants of health. And so here's where I just sort of want to go back to that point that the outcome is very complex. So you had a resource utilization, you have some sort of operational income, you have a clinical outcome, and what kind of data do you have? What is the infrastructure and what's available? How can you deploy that in the system? So the way we sort of got the historical data is very different from what it was actually deployed, but that in this case works. And so we went with a very simple logistic regression model. But the advantages of that was essentially we first created a model to predict who would get a consult, right? And so we have like a bunch of different variables with each individual weights about getting the consult. So odds, for those of you not familiar, odds essentially means, 1 means it's like a 50-50 split. Whether you have an increased or decreased risk. So we developed first a model, a logistic regression model, and each of these points has different features and their weights for getting a consult. And then we ran that exact same features, but now we put it against what are actually the odds of them getting an adverse drug event, right? Because that's a technically completely different outcome. And for the most part, they are related, right? So consults are being triggered by people for patients who generally are at higher risk for an ADE, but it wasn't actually a very perfect correlation, right? So I'm going to give you 2 examples. This one is high-risk medication. So this feature essentially identifies patients who have 1 of 5 not extremely rare, but fairly rare medications. So providers wouldn't necessarily have a lot of experience or know what to do with them, but they also were very, they have a very high rates of side effects like seizures or bleeding. And so what we found out is that sure enough, the people who had this condition had a much higher risk for having an adverse drug event, but providers were not necessarily picking that up, and they weren't necessarily initiating consults on those people. So that's where we decided, okay, we need to lift the weight of this up here. And so when we finally deploy the model, we're going to put a much higher weight on people who have a high-risk medication. Conversely, people coming from, say, skilled nurse facilities. So when people go to skilled nurse facility, there's nurses there to take care of their medications, so people don't really know what they're on. And so those histories are also quite messy. But again, getting that is a lot of work to go and find out what exactly the patient took. So providers often didn't know what the people were taking, so they requested these services, but we saw that there was actually no increase in the risk for adverse drug events. So then we were like, well, If a provider still initiates that consult, of course we'll do it, but we wouldn't necessarily add any weight on our predictive model to pick up these people additionally. And so essentially, I'm not going to go through all of them, but you get the gist that you can sort of look at, by having logistic regression model that's very simple and interpretable, you can then go look at all of these and say, okay, does it make sense for if I want to optimize on consult, if I want to optimize on AG, and put ultimately the clinical judgment and be like, well, I don't want to bring it all the way here, I'll bring it all the way here for now because I don't necessarily fully understand, right? So the final user can plug in their sort of value. Because ultimately we also, we train on 1 year of data, so it's pretty good, but still people have gotten a lot of training, and so they don't necessarily want to exactly trust all of this, right? They want to be able to put in their clinical judgment. And so again, this is the point that I sort of brought up earlier. When you do a model selection, for us, the most important thing in this case was interpretability, right? So logistic regression works. There are cases where, for example, the accuracy could be a lot higher if you use like a random forest or if you use a neural network or something like that. But in our case, that was a disadvantage because of the decreased interpretability. So those could be sometimes at odds, sometimes not. Also the deployment, so we had to deploy this within the software that the hospital was running already. So there's no way right now to deploy a random forest anyway, so there was no way of going there. We had to stick with a logistic regression. And then, how easy does that scale, right? If it's a very complicated feature, even engineering, that's going to bog down your system and you have to run it constantly, that's also probably not so good for the system. But so our features are generally simple to extract. And also updating is like how this kind of model, you can again like tweak a little bit of the weights and update it a little bit better than some other models. So this is in general the things we consider in that modeling step. And this is just one view to show essentially what the pharmacists now get is just the work list. I'm not showing you the risk scores, but then they can click on the patient who has like red is like identifying high risk, and they'll see which conditions does that patient essentially match, and then decide what to do forward. How do you communicate efficacy? This is sort of like a histogram of most of the encounters we consider as green, and the top 5% are red, and the next 5% are yellow. And so now what we see is that the very high patients who are scored very high get a lot more consults than the rest, right? So we are able to identify this is both from physicians triggering and both from the score triggering. And what was so interesting actually was that we saw that as soon as we sort of went live, so in the past, in the silent mode, the consult rate, so this is like physicians picking up correlated well with our score, right? But then as soon as we put the score live, and then the pharmacists were using the score, they were grabbing all these high-risk patients, and they were not available for the physicians to request. And so essentially, we were giving services to the patients earlier, and we were able to identify them. Now, the model is not good enough to completely replace humans, and that's not necessarily the point at this stage, but it's certainly identifying the right people, and it's catching them earlier. And there's still opportunities, of course, for growth, because we know that of people who actually ended up having adverse drug events, we know a lot of them were flagged by our system, but there were just not enough necessary resources to see them in time. So there's still a gap in improvement in terms of using maybe more resources so you can see more patients as opposed to necessarily improving the model. And we also, going back to the business understanding and the value, once the model's been running in 90 days, we did an evaluation and we see like, how did it do, right? Did it really bring value to the hospital? So that's also another point, is if you want your model to keep running, you have to explain that, it's screening everybody, it's screening a lot of people. It's not so niche and specific that it only applies to 10 or 50 people a day. And we can see that there's different documentation practices for what was prevented and what actually occurred, right? But you have to give this back to your stakeholders and make sure they understand and see the value of it so they can continue running the model or dedicating resources to improve it. And in terms of the lessons learned, there's sort of I wanted to summarize just two of them, and one of them is communication and the other one is monitoring. And by communication, I mean is this whole development process. You need to be, you start with this very crude prototype, and you start working, and you want to work with your users and the stakeholders and make sure they understand what's going on and they can offer advice and they stay engaged in the process. because I think there's still a very low level understanding what kind of data is available and what can data teach you and what is usable from this data, right? And so you have to constantly communicate that. And on the other side, from data scientists, like I'm not a clinician, I don't necessarily understand the workflows. So you have to be able to ask them like, well, why do you do this? Why do you not do this? How do you know this? And ask a lot of these questions in order to be able to build a model that reflects what's happening in reality. And you have to understand also, in a lot of places, there's a lot of documentation practice. So this is essentially user-generated data. If there's user-generated data, you need to pay special attention to make sure you know everybody's doing things consistently, or if they're not, how are they different? So you know you can trust the data that you're getting. And monitoring is, whenever you deploy something, these are complicated systems, so you never really know what's going to happen. So you still need to be able to make sure your model is performing well, the first step, but that even like all the features are being interpreted correctly and they're feeding in correctly. And again, keeping engagement throughout the process with your stakeholders to make sure they understand, like, what does that mean when I give them a score of 1.95? What does that mean? How does that relate to the other patients? So they can use it appropriately. Because ultimately here, we're providing the score, but it's not an automatic trigger decision. Like, there's a user that then uses that score to decide and pick which patients to initiate the service on. And also, like, I think the last point was teamwork. So this is, I mostly put in acknowledgements because I want to say these projects are successful if you have buy-in sort of all the way from the top from the hospital and everybody's engaged and wants to have this succeed. It's not like a pet project that you develop on your own. So we've had a great buy-in from the Parkland Hospital leadership and their inpatient teams and their IT teams, and also a lot of support from product management perspective from the PCCI, and funding from Lyda Hill Foundation to be able to develop this product and essentially have it running in the hospital and catching events.